So we're going to wrap today with a panel discussion. That includes the panelists, includes the speakers that we just had. We have another panelist who I want to introduce, or I want him to introduce himself. And then Clint Flanagan, who's the CEO, Dr. Clint Flanagan, who's the CEO, founder of Nextera Health, is going to help moderate this last panel and bring us home. So Nelson, if you would, please introduce yourself, and then when you're done, please hand the mic to Clint. I'd love for Clint to say a few words about himself and his background, and then Clint's going to moderate a panel here.
Great, thanks very much. I'm Nelson Griswald. I am with a company called Bottom Line Solutions out of Nashville. My business is working with employee benefit advisors, many of whom used to be brokers but are making the transition to a consultative advisor role to help their employers get out of healthcare 2.0 in their benefits. And you heard earlier from my friend David Contorno and my friend Dave Chase that the employee benefits industry is equally broken as healthcare is. And to prove that to you, I'm going to bring a copy of a book I recently wrote called Breaking Through the Status Quo with some of my employer benefit advisor clients. And they're struggling, we're all struggling to challenge the same entrenched status quo in employee benefits that's married to the insurance companies, as those of you in healthcare are trying to break out against the entrenched medical establishment. So it's very interesting that there is a duality going on. I spoke last year at the DPC Summit in Washington to a group of physicians who were doing DPC, and my purpose there was to explain that brokers today are no longer necessarily the agent of the insurance company, which they historically have been. Today, there are a lot of brokers who have become these advisors who are incredibly open to what you're doing in direct primary care and to other innovations going on in healthcare. So I appreciate Hint convening this. In fact, let me, to Zach and Paul and the rest of you at Hint, hats off for convening an event that brings together all the stakeholders. Again, I was in Washington last year with the DPC doctors, but there was no one else there besides the doctors, so it's tremendous to be here with everybody who has a stake in what's going on in DPC, which I agree with Cristin and everyone else is a foundational reform in healthcare. So look forward to this panel.
Well, great to have all of you on the panel. Some of you I'm meeting for the very first time. Before we get rolling too much here, I'd just like to do a shout out, a couple of them. First and foremost to Hint and the partners that are there with them. You know, some of us in this room have been with DPC for a lot of years, and it's super cool to see these solutions out there that help us take care of our patients. So I'm a family medicine and also have been doing some emergency medicine for about 15 years in Colorado. And the short is we just needed to do something different because the existing was not working. So we started a monthly membership model. At the time, we didn't even know what direct primary care was. And we've had a lot of people that have helped us on this pathway. First and foremost is my wife, Deirdre. And so we're celebrating our 20th anniversary this year. And we're going to go for a week to have some time together. That's the least that we should do because she's put up with me for about half of her lives. She's essentially not only my wife and my girlfriend and all those other things. She's also our COO and runs our business and helps on the marketing front. So she's tremendously helpful to Nextera and what we're doing. In fact, the name Nextera came from her. Even though we paid a bunch of Boulder marketing people a ton of money, she got the name. So I just would like to call out and say thanks for putting up with me, dear. So this is quite a crew up here. Usually, you know, I'm around a bunch of doctors, and I've got all kinds of questions for you guys. I'm sure the audience does too. We made our focus many years ago to take care of employers, and about 90 to 92% of the Nextera membership is employers. We take care of companies that are electricians, a couple, 4 or 5 employees. So we take care of companies that make beer, 150 of those guys. We take care of school districts, St. Vrain Valley School Districts with 55 schools and 4 to 5,000 covered lives. We take care of companies like Digital Globe that has multiple locations across the country. They're a $3 billion company. They spend about $20 million a year on health benefit, and they're self-funded. You don't, on this pathway, you don't get big fish like that until you catch the little fish. And the little fish are some of the most fun fish to catch, because you as the DPC owner of your business walk in, you meet with Jim, he owns an HVAC company, and he doesn't offer any health benefit for his employees. So America was built on those small businesses. Go after them, okay? And those are great businesses to start with, and that will allow you, as you're moving forward, to then start to target some of these bigger businesses. You aren't going to be able to catch the big fish unless you've had those small fish first, okay? And trying to hook a tuna like that is not going to happen. So just go after the little ones. Make it easy. It doesn't need to be complex. And we were doing this at a time, guys, where we were trailblazing through a lot of hustle and grind. So I'd like to talk, all of you have a tremendous amount of experience, and I'd like to, this panel is about employers and how do we, direct primary care physicians and those in the space, how do we arrange things to make them work? And obviously we have our own thoughts on that, but I'm very curious to get your experiences, and maybe we can start with you, Nelson, because you've been in this world for so many years. What can we do to help bring employers into the DPC space?
So there have been some interesting discussions today about, do you and I'll speak to the doctors here, do you as the doctor have what it takes to go in and talk to an employer? Well, especially the smaller employers, absolutely. The larger employers are a little bit dicier, and what you find is with the larger employers, they generally will defer. Well, first of all, it's the HR director who's generally managing the benefits. It's not the owner, the president, the CEO. They've delegated. Yet this decision is probably one that should be made in the C-suite by one of the executives, generally the CEO. In the smaller companies, they love the engagement that you bring to their patients as DPC doctors. So just going out and having a conversation with a smaller business, especially when they're not offering benefits, to Clint's point, is extremely powerful. So I think really let me give you a piece of advice that I got years ago from a marketing expert. He said, I don't care what business you're in, Nelson, you're in the marketing business. You may be the best consultant in town, but if you don't have any clients, you're not much of a consultant. And it's the same with being a doctor or an attorney. You've got to let people know the gift you have and the product you have and the opportunity that they have to take advantage of you. So I would urge some boldness. And if you're not talking to small businesses, go talk to them. They're a small business owner just like you are, and you can relate on that level as well.
Yeah, go ahead, Sally.
So from the large employer perspective, what you need to understand, and then I'm going to, definitionally, I'll say jumbo, right? So jumbo is anybody over, I'm going to go down pretty far, anybody over 25,000 employees, we'll call that jumbo. Actually, jumbo employers are not doing DPC, but they are in droves doing on-site care and on-site clinics, right? Which is another angle on what you guys are doing. So if you think about it, if they are trying to solve the same issue, which is they're seeing that they want their patients to have access and convenience. And, oh, by the way, there may be some cost savings, but that's not the driver. Generally, for the on-site or near-site clinic, generally it's about convenience and access, integration. They may be integrating their other toolkits like their navigation, their nurse case managers, their concierge elements. So I think if you're thinking about marketing or selling into the large employers, thinking about it from that perspective, that they've already solved it with the on-site. With Nextera has done some, I think, right, on-site or near-site clinics, right? So that's the way that the larger employers are thinking about it. So it's just a different angle, but that might be the plug into it.
So a couple of, one point, Sally, a kind of question. So you have tremendous expertise in the HR arena. decades? Okay. I think you had said since dirt, which was pretty impressive. So I'm super curious, in all of those years, did you ever have physicians at the table when they were negotiating benefit?
For negotiating benefits?
So when you were looking at your benefit package for employees, were there ever physicians there? We understand the brokers there.
Yeah.
Did you ever have physicians, for example, primary care physicians? So you're buying a service,
Right.
right?
So
And-
quite often, many employers actually have a medical director, a corporate medical director, who is a partner with them on developing the benefit strategy. Or if you don't have a medical director, we used to have one that was on contract that we would access. So jumbos often will have a corporate medical director that will help them. The corporate medical director may do other stuff. They may be doing the safety and all that kind of thing too. But most employers, jumbos, are also capitalizing on a doctor for benefit strategy.
So, I think it's interesting, and realize that a lot of this that has been done for years in the DPC world now, it was difficult getting into that room. So typically the broker's there on behalf of the employer group, right? And they're buying a service, and they have no clue what's in their PPO network as a family, with regards to family medicine physicians or internists or primary care providers. So they're spending a lot of money for a fancy PPO plan, and yet that family medicine doctor or internist is seeing 25 to 35 patients a day. It takes a month or two to get into him or her. He or she is very burned out on answering patient portal detail that they're not getting paid for. It's not the physician's fault. The physician's just in the wrong business model. It's in the wrong model. So it's unfortunate because he or she's overworked, and the incentives are wrong there, right? Their patients are transactions. And so a bit of what I'm getting at is we've created a model, and we need to represent that. And to your point, we need to sell that. We need to talk to the employers. From our infancy at Nextera, we go to the employer health benefit meetings, and the brokers love it. So we're working in partnership with them, and we're on the stage talking to the employers and the truckers and the HVAC guys and the plumbers, and we're like, yeah, here's our doctors. So imagine that, right? Because a lot of times the company's buying something, they don't even know who the doctors are. Where else in America do we do that? We always know, right, what we're buying and for the most part what we're getting. So make it a part of your DPC if you want to target employer groups, whether it's 5 plumbers or whether it's 500 guys that are truckers, or whether it's the school district, to make sure that you're a part of that employee health benefit. And no one can tell your story better than you, the DPC physician. Work in tandem with these teams. You have to work with HR. It's critical. They're the decision makers, and they're helping you sell, and they're some of your best pals when they're trying to pitch that to the CFO to bite off on that cost. Work with the broker team. I think, Tamara, what you're offering is tremendous on many fronts. Can you and or Sally, or even maybe Dr. Dickerson or Nelson, talk about self-funded, bundled programs and unbundling them? And if you have a self-funded entity, how do you unbundle that rather than one big package? You mentioned Vivio Health earlier. There's companies like ZeroCard. There's Cure. Because we can affect the primary care spend in many ways as DPC docs, but there's these other huge spends that companies are shelling out for United contracted rates for back surgeries. What about direct contracting on that front? And I really got the impression that that's what Cure does a lot of.
Well, right now we're working primarily with payers, and what we're realizing is that our patients are just paying too much because of that payer overhead. Most payers can't process a bundled claim. So in addition to the crazy 17.5% MLR that is thrown on top of all of the fees that are being paid out to the physicians in the facilities, we're in addition having to go out and contract with a TPA to process the claims. And so, that leads us to the belief that, well, why are we bothering to pay the insurance company to process those claims when we're paying a TPA to process the claims? So why not work directly with employers and cut out that middleman? Because at the end of the day, the goal here is to try to cut out unnecessary costs, and it's very clear that that layer is unnecessary. When it comes to bundling and unbundling, I'm a big believer that, when you are delivering a solution, and I've been in health tech for a while now, and it's advice I give to a lot of startups, which is employers, payers, any really big enterprise customer that you might be selling to, no one wants to buy from little vendors. So the smartest strategy to really sell in is to get creative and work together to bundle the bundles, to actually not unbundle, but bundle more. Find yourself in your local geography, somebody who's doing ortho, somebody who's doing maternity, someone who's doing imaging, somebody who's doing direct primary care. Put it together, slap a name on it, find a creative broker, and go take that to your local employers. Because that's an interesting package. Now you're nailing the top 5 or 6 things that an employer is really, really concerned about, those really big vectors of cost. And when you add the direct care, primary care layer, you're also adding essentially that concierge service that makes sure care is directed at the right places. And when you're looking at these spot providers who are really focused on appropriate care, you're starting to address those key concerns that Sally was raising, which are shared by every employer. When I was at HealthSpark, which is the previous incarnation, that was the primary goal. We were there to please the large employer customers, the self-insured employer customers. And the reality is that their big goal was to steer patients away from unnecessary care. And I believe that primary care is the real root of how we do that effectively, and specialty care has to partner with primary care effectively. And because we're living in silos, we're not really going to be able to sell that real solution that really step functions cost down. But if we start working together, we certainly can. Sally probably has a lot more advanced thoughts on this.
Well, I think that we are in a little bit of a transitional phase right now, because as I said, we literally, I work with a group called the Employer Health Innovation Roundtable, and its whole purpose is to be a forum for startups to come forward to employers and get a chance to pitch. It's sort of a Shark Tanky thing where they can pitch their solution to the large employers that are members of the group. And it's a biannual thing, and we had almost 100 submissions this past spring to come try to pitch to the employers. We only picked 8 or 10 for each session. So we are really in a part of a wave right now where there's just all these little, we call them point solutions, and the employers have been buying these little point solutions, big employers and small employers, and I think they're starting to go, okay, I'm starting to drown with the number of vendors I'm having to manage, because the consultants, quite frankly, are not helping us manage them. We're doing it all on our own. And our HIPAA requirements, our security requirements, our contracting requirements, our procurement requirements, all of those are just drowning us. So I think there will be a natural evolution to some kind of, I hate to use the word bundling, but platform management, where you can have platforms that have either plug and play or integrated systems or integrated elements that you can bring forward. I think that might be a few years in the future, but I think that's where it's going to go.
So fortunately, the bar, I think, is set pretty low when it comes to employers, and you mentioned this, Sally, in actually the care they're getting. So we like to look at that as a tremendous opportunity, because these employers are paying oftentimes double-digit rates higher per year, and they're not getting any better care for that, right? Not getting any better care, yet they're paying more. So that's an opportunity for all the DPCers in the crowd that are interested in targeting employer groups. So you have the groups that don't have any health benefit, okay? And then you have those that are fully insured. They're paying 10, 15% more for their Cigna plan, yet getting no better care. And then you go all the way to the self-funded groups that again, are paying more, yet getting less care. And it's interesting, some of these companies, you mentioned on-site and near-site, are spending significant amounts of money and they have beautiful big buildings, and they don't have any on-site clinic. So if you have that ability to do that, that's an opportunity, and you can oftentimes do that as a direct primary care physician. You don't even have to charge them anything because they're writing you a monthly check. And that allows you to take the staff and physicians and be there on site, affecting things like absenteeism, presenteeism, hiring, retention. One of the companies we work with on the on-site, they walk new employees by the clinic and say you can go there anytime you'd like. And so that's another value add of what you can provide as a direct primary care physician to the employer groups that you're working with to strengthen that relationship. So I'm curious, Dr. Dickerson, with regards to your experience as a radiologist and understanding a bit of what we do here in the DPC space, what are, like, if you were to make arrangements, and you alluded to that a little bit in your presentation, what's like the top 2 or 3 arrangements you would make with the DPC world when it comes to the services that you can provide?
I think working in partnership with Dr. Goyle, I do have about 6 practices, DPC practices in Houston with whom I work, and then a number in Austin as well. I really haven't broken into the other markets very well. But we would be willing, most of the DPC doctors I work with don't really want to upcharge for the imaging. They really want to work, to save the employer's money or save the individual's money. We can go, if they're already working for an employer, we do a lot of direct contracting. So we could go do a direct contract with that same small to mid-sized employer or the TPA who's managing that to provide imaging services and hold down that cost. That takes that off the DPC's plate. Right now they're having to find I've got 45 imaging centers in the Houston area. So we can handle that concierge piece that they're already handling. So one of the ways that I can really help a DPC practice is just take the imaging off their plate. Everything's going to be in the same PACS system. All the reports, they have our text numbers to text us if they have a question about the report or call us. We have a radiologist of the day. We have an Ask the Radiologist option on our website. And in fact, Ask the Radiologist we set up to be a patient tool, and I get 5 times more inquiries from physicians than I do from patients on that tool.
In that with what you just mentioned, do you find, let's say it's an employer with 3,000 employees and you have a direct contract with that employer, do you find that, are you just billing them once a month then for the MRI and the X-ray and the CT scan, et cetera? What if that employer has some patients that have high deductible HSAs and the patients bears a cost a little bit? How are those arrangements taking place for the patient that, let's say, is on a PPO plan with no deductible and a self-funded company versus the same company that they're on a high deductible HSA? How is that transaction happening?
Well, that's an interesting question because I didn't get to some of my slides, but one of them is this a cash arrangement or is it not a cash arrangement? And the direct contracts with employers and TPAs are frequently not cash arrangements. They feel a lot more like old insurance where I'm figuring out. Now, I don't have to get an auth typically. Sometimes we have to get an auth with these arrangements, but many times I don't have to get an auth because it's coming from a DPC doctor. They've already vetted the study. We do handle the patient responsibility. We have tools for easy patient payment. Actually, Acerta has a beautiful program, platform for breaking out. You can build an algorithm, and we hopefully will be online with them in the next few months, where that you build an algorithm for what that employer's plan is, and so it divides it out. And when it's funded either by the patient and or the employer, it gets broken out. To say, the imaging center I can pay, say they're 60% of the cost, and then 40% goes to green imaging, all of those things. And we'll be able to do that with bundled surgeries as well on the Acerta platform. Break out to the individual, it looks bundled to the employer, but it gets broken out at the payment end to the doctors, not the providers.
Thank you. So I'm curious, Nelson, for the physicians in the crowd that are interested in getting into the employer space, understanding that relationship is oftentimes very tight between the broker and the employer, and understanding that there's compensation involved with broker and insurance company. And how does the DPC doctor and or his or her team get into that circle? understanding that oftentimes the DPC doctor wants to keep that per member per month very affordable, and they don't perhaps have the bandwidth, nor do they want to pay the broker. So how does that work?
Find the right broker. So here's the big picture. We talk about breaking through the status quo. Break the status quo. We talk about breaking through the status quo. What is the status quo? We identified it. It's the status quo broker, the big brokerage houses, and the insurance companies, health insurance companies. They are married. They are connected at the hip. The insurance companies pay these brokers. They love fully insured plans. They're easy to put in place, and there is no room for you in a fully insured plan. They will not carve out primary care. They're not interested. Plus, they'd want to be paid, and they'd want to be paid a lot. You need to work with what we call next generation benefit advisors. And these are brokers who are looking at this new model, this new approach. First of all, the plans, the companies need to be self-insured. Don't want to go into the detail, but there's not an insurance company involved. Second, the great thing about what's happening is that wall is coming down, and the advisors are moving through the wall to engage the providers. For the first time, one side's reaching out to the other beyond just throwing money over the wall to pay the providers. Those advisors who are going through the wall and working with doctors like you are interested in finding a way to integrate you into their health plan. Don't waste your time on traditional brokers. You can try, go ahead, but they're not going to be interested. But these next generation advisors, those working with Health Rosetta, those working with my organization, are very open, and they're open to the bundling as well, because one of the new jobs of a broker, next generation advisor, is to manage the healthcare supply chain, which simply means managing those cost centers that the employer has, physicians, hospitals, imaging, to make sure that it's high quality and low cost. Well, who provides high quality and low cost? A DPC office. So these advisors are very open to working with you. That's who you should look for, and you'll find a very receptive ear.
Thanks for that. So we're closing up on our time here. I just have one last question, and maybe if it works, we can open it up to the crowd, depending on what Hint would like to do. First off, do any of you have a primary care physician? I see heads nodding. Do you have your physician's cell phone, email, and if you texted or called him right now, would he or she respond to you? Yes, and then 3 no's. So perhaps we could find where you guys live and get you a direct primary care physician. So Mike, I'll hand that to you, and you take it.
Excellent. Guys, thanks for the journey today. It was a lot of content. We made it.